This is a presentation about factors affecting rehabilitation and performance of a stroke patient. The case study. So we have a 50-year-old female who suffered a stroke 3 years ago, and the stroke caused brain damage to the right side of the brain. She currently suffers from poor balance and a drop foot on the left foot. She uses a walking stick and support from surrounding furniture. And as a result of her poor balance and drop foot, she often trips and falls. Her main goal is to be able to walk to the corner shop, buy a newspaper without tripping and falling. So an introduction on stroke. Stroke is a medical emergency that results in damage to the brain, which causes movements to be affected due to neurological pathway disruptions. Stroke is the main cause of acquired adult disability, and there are two types of stroke. The ischemic stroke is caused by a clot, and the hemorrhagic stroke is caused by a bleed. The one that is highlighted there in the middle is a transient ischemic attack, otherwise known as TIA, but this is also known as a mini stroke, which usually resolves within 24 hours. Over 100,000 strokes in the UK yearly. Stroke is the fourth biggest killer. Almost 2/3 of stroke survivors leave hospital with a disability, and 1/3 of stroke survivors experience depression after a stroke. Brain anatomy to gain further understanding of the impact of stroke. So the brain is made up of two cerebral hemispheres, right and left, and spinal nerves cross over through the medulla oblongata, and this is how the right side of the brain controls the left side of the body and vice versa. So the right side of the brain is responsible for proprioception, balance, what you see and where you perceive things, along with movement and sensation of the left side of the body. Whilst the left side of the brain is responsible for cognition, language, speech, and movement and sensation of the right side of the body. Therefore, understanding the area of the brain that damage has occurred following a stroke is important with the rehab pathway and program planning to ensure that the patient can perform the movements and utilise the skills required to the best of their ability, with the brain damage injury extent in mind and at the forefront of the rehabilitation program. With this in mind, the brain is subcategorized into 4 lobes: frontal, parietal, temporal, and occipital. On the previous slide, I mentioned the 4 lobes, and here I talk about their functions. So the frontal is responsible for the motor movements, parietal is responsible for sensory information, temporal is hearing, learning, and memory, and occipital is vision and perception. Risk factors associated with stroke are high blood pressure, heart problems, previous TIA, diabetes, high cholesterol, smoking, diet, inactivity, alcohol, along with 50+ years of age at higher risk and males. However, women are at higher risk when hormone changes, contraception, childbirth, and pregnancy. A robust rehabilitation plan needs to determine factors affecting the patient's rehabilitation and performance by addressing the patient's needs. As I mentioned in the previous slide, this is by a needs analysis. Also, a subjective and objective assessment to identify the patient's current status. Once these factors are addressed, this can be linked to patient-specific outcome goals which meet the patient's needs and current status. Given that the patient is currently suffering with poor balance, left drop foot, and subsequently often trips and falls, it is important to understand how mechanically this can be affected, but also neurologically. Therefore, the neurological rehabilitation is going to play an essential part within the rehabilitation plan to maximise recovery. As I mentioned as well on the previous slide, functions of the lobes are important to understanding to have an idea of what the patient might be suffering with. So in the temporal brain, it is linking back to the memory side of things. So if the patient is not able to remember things, this might have an effect on what exercises you prescribe, how you prescribe them, and how the patient carries them exercises out. So it might be a good idea to either try and see the patient more often, um, try and write down the exercises, or point her in the direction of videos that she can watch, or have her perform the exercises and then record them for her to take home, or even send in reminders if that is an option. Patient-specific considerations. A 50-year-old female who suffered a stroke 3 years ago. The stroke had caused damage to the right side of the brain, which has affected the left side of her body, in particular the left drop foot. She also suffers with poor balance and as a result often trips and falls. She also uses a stick and support from surrounding furniture. With these identified as problematic for the individual, the importance of addressing these considerations is to reduce the risk of tripping and falling, whilst maximising potential progress for the patient with activity of daily living. Ultimately, we want to home in on her main goal, which is to be able to walk independently to the local shop to collect a newspaper without tripping and falling. So the rehabilitation programme with patient-specific considerations justified. When considering the age of this patient, although it is still a relatively young age, the population is understood to be 50 plus years of age at higher risk of suffering from a stroke. Also, being that the patient is female, this heightens the risk potential due to hormonal changes of that when menopause occurs, which is females between 45 and 55 years of age. When considering the patient's current problematic considerations, the importance of being aware that the patient is having a left drop foot is to firstly be able to understand that this is a left side deficit which links back to the right side of the brain. And this implies that her perception and movement on the left side of the body is being affected. Therefore, being aware to again link that to neurological aspects of how the patient perceives things and subsequently how this transpires into functional movements. In addition, the patient also walks with a stick and support from surrounding furniture. This also emphasises the aspects of biopsychosocial model. She shows signs of fear avoidance and uncertainty, and her own beliefs and that her end goal is unobtainable. It's quite detrimental to her mental state and depression. It is important to bear in mind that exercises need to be repetitive and neurological rehabilitation is crucial for relearning and helping to make changes, whilst we also need to home in on the patient's end goal. Single rehabilitation session. A circuit class training based rehabilitation session with 7 stations. So there will be a 5-minute warm up, 3 minutes within each station, 3 minutes rest, 1 minute to change from station to station, followed by 6-minute cool down at the end of the session. In total, 60 minutes. So the first station is standing and reaching out. So alternate direction of reach and arms. This is to help with orientating self in space and to be aware of centre of mass. Stair climbing is the second station. Third station is sit to stand. Fourth is in sitting, start extending and flexing the knee in a slow and controlled movement. You can also use a prompt to stimulate a sensory response too. In standing, swing the leg forwards and backwards in a slow and controlled movement. Think about swinging the motion and controlling from the hip. Whilst station 6 is walking 3 steps and reaching out. Alternate direction of reach and arms after each 3 steps. Walking course with obstacles, so this could be cones or shoes, books, just anything to try and make the patient be aware that, sometimes when out walking, there could be things on the path, on the pavement that are in the way, and she might have to avoid them to minimise risk of tripping and falling. So repetitive reps to help with the motor recovery and cognitive function, which is where receiving information by perception occurs. Ultimately, being task orientated, thinking about the task and the importance of the patient understanding the task before they then proceed with the task and how the task subsequently be carried out by the patient. Break down into simple tasks. So to master all aspects of the end goal, the end task, to build back up to the full task. We want to restore the movement capabilities of ADLs and making sure that we're aware of the afferent and efferent neurological pathways, so reconnecting them neurologically. This will help to link the rehabilitation program specifically to a patient with history of stroke and aid in the brain's ability to relearn months and years on. Ultimately, we are maximising the patient's potential to progress through rehabilitation in a functional way and whilst addressing the neurological issues too. I've suggested home exercises to help with repetitiveness of exercises, cognitive recognition, and to help with the small peripheral muscles, in particular the drop foot. So the bigger global muscles have a greater chance of coming back than that of the smaller peripheral muscles. And in the case of this patient, the peripheral muscles relate to her left drop foot. Therefore, the global muscles, the bigger muscles, are relating to the hip flexor muscles. As a result of the left drop foot, hip circumduction can happen and occur through the gait cycle. If the hip flexor doesn't give sufficient ground clearance during the swing phase of gait, the drop foot will have a likely occurrence of the toe catching on the ground, subsequently causing the patient to trip or fall. Okay, so we want to emphasize the importance of cognitive and perceptual function as well as motor function. So really focusing on relearning activities, motor relearning, and where the functional compensations are occurring. So impaired balance, the body devises a compensatory movement strategy that allows you to reach a movement outcome. However, this movement isn't necessarily the desired functional movement outcome, and therefore the rehabilitation should be directed at determining the compensatory movements, focusing on what needs to be adapted. Through repetitive movement strategies, you utilize the efficiency of repeating a task with functional outcomes. Therefore, during the rehabilitation sessions, look for movement compensations, and the aim is to remove abnormal movement patterns to encourage normal movement patterns. 1 month rehabilitation program. So mirror for biofeedback, checking with the patient. Do you think that you're in the middle? Encouraging the patient to understand the center of mass by re-educating balance. Similarly to the sit to stand between parallel bars, encouraging, perception and awareness and whether they're able to orientate themselves in space, if they can close their eyes and do it again. Again, play with weight transfer, so rocking forwards and backwards, side to side. So gait re-education stays from 4 and 5 from the one single session. Again, this is from familiarity and to repetitiveness to keep it, similar because of the patient's symptoms from a stroke and memory. And obviously highlighting gait re-education. Similarly, hydrotherapy is going to help with balance as well, counteracting gravity forces with buoyancy. So the exercises I have listed here are to continue the recognition and re-education of gait and improving balance, whilst also trying to mimic that of outdoor walking. So the patient's end goal in mind, the different terrains that she could walk on, potentially come across, pavements, stony pathways. And so all of that could be encouraged early on in the rehab by, taking socks off, putting them back on, wearing shoes, not wearing shoes. And I have listed a few down there. So there have been studies that have been carried out which show that 5 days a week, 45-minute sessions show significant improvement in gait and functional status, as well as 4, 12 and 24-week programs. Okay, so the 1-month rehabilitation program has been directed to help continue to re-educate the patient with gait, encouraging muscle activation and ultimately increasing muscle strength. This will help to encourage the patient to take responsibility for the rehabilitation program, whilst gaining a greater understanding required about their centre of mass and functional movement pattern outcomes. Hydrotherapy alongside land-based rehabilitation exercises following a stroke have distinguished advances from that of just a land-based rehabilitation program. So these advances have been observed predominantly in increased muscular strength of the lower extremities, motor function in walking, and control of balance. Stroke is noted to be disabling and a form of paralysis. And therefore there is a concept known as bow bath, which is widely used with stroke patients to help guide treatment. The bow bath concept deems it necessary to have normal muscle tone to be able to produce normal movement, and subsequently this will improve functional movement. In addition, task-orientated exercises are preferred in regards to quality of movement from a motor relearning rehabilitation program. Further supported evidence shows that task-orientated exercises have been achieved through circuit class training, which show activity of daily living and gait improvements after 4 and 12-week programs. Ultimately, again, we want to have the patient's main goal in mind, and we want to build up that confidence and ability of the patient to be able to do that. So, time for some fun. There is evidence supporting non-immersive virtual reality exercises, which are exercises that can be carried out on a games console, in particular Wii Sports, skiing and yoga. So these help to make exercising more exciting, engaging and fun from home. So hopefully, it will help to highlight the centre of mass importance and encouraging balance for the patient. Also, it supports a biopsychosocial model because it can encourage biofeedback and potential social factors. So the patient can play Wii Sports, skiing game with family and friends. Similarly, patients can lose interest and discontinue exercise sessions. However, with the non-immersive virtual reality exercises, patients are still taking part in task-orientated functional movement rehabilitation, just in the comfort of their own home or family and friends' homes without discontinuing exercise. Thanks for listening. Any questions?